As you know, after I studied medicine, I graduated from the National Institute of Neurology and Neurosurgery in Mexico City, where I became at that time, 20-something years ago, a neurosurgeon, which is specialized in brain and spine surgery. So I went to Austria with Professor von Strempel, which is a tremendous orthopedic surgeon which defends over his dead body, not to fusion, but stabilization, and keep the movement or the normal, try to keep the normal movement of the spine. So I did a lot of procedures there with him under one specific design of him, which are transpedicular screws, which have this hinge in the head of the screw, so they don't fuse the segment in the lumbar spine, but they allowed this flexion and extension, which is normal in the spine, to preserve that. So I have had some beautiful results with that system. Also, they developed there in Germany at Ulm, is a company there called Ulrich, which developed a prosthesis for the C-spine, which also promotes not fusion, but stabilization and keep the movement, the normal movement of the C-spine. That is called the Rotaio artificial disc. And I think it's a beautiful piece of engineering, biomedical engineering. And the results with that, it's, what can I tell you? They are beautiful. The patient goes to the OR, and maybe the same day or at most 2 days after the operation, they can go home. They don't use any braces, neck cord, nothing in the neck. They just go to the OR. If everything is fine in the post-operative period, they go home between 24 and 48 hours at most. We're doing the same in the lumbar spine, trying to do always minimally invasive surgery according to the patient. There are some patients who are candidates for minimally invasive procedures, and sometimes the patients need more opening or more aggressive procedures. That's why we need always, in every patient, to have a history of their complaints, and also have always x-rays in 6 positions, which are AP, which is a front image of the spine, C, thoracic or lumbar spine, a lateral view, and oblique views always, which show us the little holes where the roots escape from the spinal canal, and that can be seen in the oblique views. And the other 2 projections are inflection and extension. That's a dynamic form to see the movement of the spine. Sometimes in a static view, you just can see the vertebra, where they are, if they're complete, if they don't have fractures or tumors or whatever. Sometimes if the tumor depends on the bone. But some patients complain of only neck pain or lumbar pain without radicular pain, and this is caused sometimes because of instability of that segment. And you can see that instability only in moving pictures like flexion or extension x-rays. That way, and also with an MRI or sometimes a CAT scan, we can have the whole picture of the problem and to be absolutely sure of what are the needs of each patient. If the clinical symptoms and all the complaints of the patient we can put together with the changes in the images, X-rays, MRIs, or CAT scans, that way we can be sure what is the problem and if it can be solved by surgery. I don't like to gamble what I never like to lose. So I always want to be sure, at least 90%, if the complaints and the X-rays are compatible, we can offer good results to the patients. I'd rather operate 100 patients with excellent results than 1,000 patients with so-so results.
And I want to thank you very much for watching the video today.